thank you everybody for coming this afternoon. Appreciate your time and your efforts for getting here. I know it takes something to get here. Sands has you park half a mile away, and I'm sure you're here not because your back and legs are feeling great. You're here because you probably have some interest because maybe you have some problems or have some friends that have problems, want to get some information or some free stuff. The last time my mother-in-law was here, my mother-in-law, here I am speaking, and my mother-in-law, who's from, she calls it the coal region, she lives in Pottsville, or she's from Pottsville, both my in-laws are from Pottsville, and she literally left with a bag full of the free cookies. And I said, you can't do that. You can't do that. But she did it, and she does stuff like that all the time. So anyway, Dr. Goldberg and I work together at Coordinated Health. We're going to go over a few things. We'll save our questions for the both of us, I think, for the end, and appreciate that. But we're here to answer some of your questions, and hopefully you find this informative. We'll try to keep it a little bit loose, but again, the questions at the very end. So my professional interest is in minimally invasive surgery of the spine, and so a lot of patients I look to do that. Not everybody is a candidate, but that is my professional interest, and we'll go over some of the reasons for that. So, did I put this in? This is a disclaimer. No one wants to take credit for what I say or do, unless it's positive. But they never. I think they put this in just because they know I might say some things that they don't want. But anyway, it's not intended as a substitute for personal, professional, medical advice. You can read that. Typical lawyers involved in medicine. All right, so we'll go over some basic anatomy. Most of this is geared towards the low back or lumbar spine, but almost everything can be extrapolated to the neck. So when we talk about disc herniations and bone spurs and stenosis, almost everything can be extrapolated to the neck. If we're talking about the back, most of it you can talk about or can be related to the neck just the same. We'll go over some basic problems of the neck and back, and then we'll talk about some of the operative treatment and non-operative treatments. This is where I trained my final destination. That's the Mayo Clinic. Everything you see there is all hospital and hospital clinics. People with big problems actually move to Rochester, Minnesota and live there just to be close to the Mayo Clinic. It was an incredible experience, and in a lot of respects I miss it a lot. But this is a basic model of the spine here. The cervical spine refers to this area up here. That's the neck. There are 7 cervical vertebrae labeled 1 through 7, so the top one is C1, the bottom one is C7. And then below that is the thoracic spine. There are 12 thoracic vertebrae labeled from 1 to 12, so this would be T11, this is T12. This is the lumbar spine labeled 1 through 5, so this would be L5, this would be L1, and then finally is 5 fused vertebrae that make up the sacrum. The one we talk about most is S1. So if you have a problem at L5, S1, that would be in between here, between L5 and S1. Here is another model, again, of the back, because I like to use the back. It's easier, it's bigger, it's easy to see things. And you can see the vertebra as they are labeled. And here is an individual vertebra looking at it from the side, and here is it looking as if you're looking basically from the feet up. And everything that I do as a surgeon, most of the things that I do are related to these holes. Everything is about these holes. Is there pinching in the hole? Is there room for the nerve in the hole? Okay? And you may see words like foramen on an MRI report or central canal. All that refers to, this is the central canal. So the brain is a big ball of nerves, and that terminates as the spinal cord, which is a rope-like structure full of nerves. And then like branches on a tree off of the spinal cord, these nerves will flow out from the spinal cord or the end of the spinal cord and flow out to your arms and your legs through holes. So the center hole, that would be the central canal. You can get pinching in that hole. You can get pinching in these small holes within the foramen. Dr. Goldberg will tell you about transforaminal injections. Those go in those holes. But everything is about that hole, those hole sizes, and getting the nerves through that hole without being pinched. Okay? If you have stenosis, we'll go over this, but I'm going to run through it. Stenosis, everybody thinks it's some crazy, important, complicated term. It just means pinching. And just anytime you see the word or hear the word today of stenosis, just substitute that with pinching, whether it's a bone spur or herniated disc. It doesn't matter, it's pinching. So that's what stenosis is. So it's all about these holes. And again, these are the holes we're talking about. Here is looking at the spine from the side. You see a bone and bone. In between the bones is the disc. The disc is like the shock absorber, also allows for motion, allows for some motion. People think if you get a fusion in your back that you're not going to be able to move. And I think that's internet fodder and insanity. If you fused your whole back, you would still have 60% of this motion, because that comes from the hip. And I've never done a 1 or 2 level fusion where if the person could touch their toes before the operation, that they couldn't touch it after the operation. So I think that idea that if we fuse your neck, if we do a 1 level fusion, that you're not going to be able to turn your neck. I've never seen that if you can't turn your neck after a 1 level fusion, it's because you don't want to turn your neck or you have some other problem. But it's not because we're fusing one of these many vertebrae that you're not going to be able to bend. That's crazy. And the reality is, half of the people sitting in this room, you're not elite gymnasts or athletes. What are you bending for? Okay, you'll all be able to tie your shoes afterwards. And if you can, it's not because you have a 1 level fusion or some problem at 1 level of your back. So these holes, you can see, look at the proximity of these holes to these discs. Okay, and you could say if you developed a bone spur on the back of this disc, or a disc herniation where a portion of this disc somehow becomes dislodged, it's going to touch these holes. You can see the nerves coming out here, the nerves coming down. And so if a disc herniates, it's going to touch those holes. If you develop bone spurs, it can cause pinching within that neuroforamen, that hole, as the nerves exit the spine. And not showing up really great here, but you can see these degenerative changes that you get with time. That's actually the disc. This disc is collapsed. This is actually a gross specimen of from a cadaver cut in the sagittal plane. And these are the bone spurs that are sort of projecting off of here into the neuroforamen. And they cause that crowding or the stenosis within the foramen, which may end up leading to neck pain or back pain or leg pain or arm pain, as it were. So if you also see the word spondylosis, is a fancy word radiologists use for arthritis. It just means the basic degenerative changes that one might see in the spine. Spondylolysis, you may see that, and that is a stress fracture that probably occurred when people were, normally it's a stress fracture, that occurred when people were in their teenage years or slightly before. And then something that a lot of people end up having, particularly more women than men, is what's called spondylolisthesis, which is a big word, and it simply means that one bone has decided to slide relative to the other one, slide forward, and we'll look at, I think, some examples of that. But if arthritis sets in, the joints don't work quite as well, they don't match up, that sort of connection between the two pieces of cartilage don't quite line up, and we'll go over some changes, but the bones will start to slide, and when bones slide relative to one another, then all of a sudden the tubes don't line up between L4 and L5, and then we get some pinching. We'll go over some of that. But spondylolisthesis, you may see it as anterolisthesis or lateralisthesis. That's just the different directions that the bones may slide. Radiculopathy refers to an injury to a nerve root. Radiculitis is inflammation of a nerve root. Claudication is something we talk about a lot. That's when nerves are pinched, you have stenosis typically in the central canal, in the low back, and when you're walking, your legs feel heavy and you can't walk far, or your butt feels like it starts to hurt when you walk across the expo floor here. And then finally, myelopathy. That's something that we see in the cervical or thoracic spine when the spinal cord itself is pinched and it gets sick and it doesn't function quite as well, and that can cause its own problems. So the aging spine, when I was a resident at Georgetown, very famous spine surgeon and wrote all these big texts, he explained it to a patient and it always stuck with me. when that patient was asking, why did I get these bone spurs? Why did I get this spinal stenosis? And he said, you see those wrinkles on your face? Well, these are the wrinkles on your back. And that really, I thought, resonated with me, because as we get older, tissues change. All tissues change, whether it's your skin tissue, your dermis, or it's the tissues in your back, whether it's at the level of the disc. In this particular case, your discs, which we saw are those spaces in between. As you get older, you'll get loss of water. And what happens is the disc gets flatter. That's why we're all getting shorter. No one here is enjoying a second adolescence where we're getting taller and stronger and nicer looking, right? We're all getting shorter and full of wrinkles, myself included. So we've got loss of water. There's a change in chemical composition. The chemicals, the actual proteins and collagens, things change in there. Some actually increase, some decrease. The disc will then collapse. The cartilage will lose some cartilage in what are called the facet joints. Then you get this abnormal motion, just like if you had a bad knee. We've all seen people with bad knees or arthritis in the hands, and we'll maybe see some pictures of that. Things change, you lose cartilage, you start getting deformities, knees start turning this way, fingers, the tips of your fingers start going the other way, and extra bone forms. And that's the body's way to kind of slow down this abnormal motion. Your body forms bone, which makes you stiff, but sometimes not only you stiff, there's pinching of the nerves, right? So I love this slide, kind of busy, but it gives you this degenerative cascade that leads to spinal stenosis, whether it's at the level of the disc, where the disc starts getting these tears, ultimately getting internal disruption, the disc gets shorter, leading to getting bone spurs, or as this is happening, you could get changes in the smaller joints in the back, what are called facet joints. Dr. Goldberg may talk about some injections with the facet joints, leading to all of it leads to this instability, nerve entrapment, stenosis, and then the quality of life gets affected. Again, here are those osteoarthritic and degenerative changes that we can see. We can observe these in our friends, in our family, and ourselves. It's tougher to look at the back. All we know is we have pain, or we're shrinking, or we can't do the things that we wanted to do. But this is a very obvious look at things. Everybody knows somebody who has hands that look like this, or that knee. That's what's happening. Again, you're losing that cartilage. It's going to start forming some bone spurs as the body tries to stabilize this joint that has abnormal motion. Some people will get knees that move out this way, or they become bow-legged. But they do get these bulbous looking knees. And the osteoarthritis of the spine, we can't see quite as well, but we can feel. And then again, this is the gross sections of the spine, these being the bones, these being nice, juicy, healthy, wonderful discs that we all wish we had. Mine don't look like this either. I've had several MRIs on my back. As we get time, we get that loss of water, change in chemical composition, and this sort of collapse that we see, and then you get these disc protrusions. The nerves are back here, and you end up, you can end up getting some pain and disability. Not everybody who has these type of changes, in fact most people don't have pain and disability, but some people will have symptoms related to this. And this is again all the pathology, or a lot of the pathology that I commonly see, which include this very degenerative discs rather than having these super big normal high discs. Down here at L5S1, it's collapsed with the bone spurs. Here's a disc herniation represented here, sort of a disc bulge. Very common in a lot of the MRIs that Dr. Goldberg and I will look at on a daily basis. Another example, this is an MRI looking at you from the side, and again, we'd all wish for a spine that looks like this. We'd all wish. And why do I say that? Big discs. Here's this area between here and here. That white stuff is fluid. That's your spinal fluid. Maybe you've heard of the term if you have a spinal fluid leak, or you had an epidural when you were having a baby and they were worried about a leak. But that fluid is there to protect the nerves. The nerves just float around in that tube of fluid. We don't want anything touching the nerves. Okay, that's why there's that fluid. And this is the end of your spinal cord, incidentally, and these are the nerves sort of floating around in that fluid before they exit out. This is a beautiful spine. But if you fast forward, this is the kind of thing that can happen where you have sort of in some of these areas, not a perfect sagittal cut, but you can see that these are collapsed. You can see these disc bulges, and there's a lot less fluid. We know the fluid has nerves in it. We know that the nerves are being pinched. Okay? Same thing with the neck. We'd all wish to have this spine is not a bad looking spine. You can see this is the tongue and the mouth. Here is the end of the brain, the bottom of the brain stem, the cerebellum. And here is the spinal cord, and we see the spinal cord again floating in this fluid. We don't want a whole lot touching the spinal cord, certainly touching it a lot. And then this is what can happen. This is a very typical older patient where the discs have collapsed. We get all this bulging. Now we don't see a lot of fluid around that cord at all. We get a lot of pinching, and that's a patient that might have radiculopathy or arm pain because the peripheral nerves or the nerves as they exit might get pinched, or the spinal cord might get pinched and they have cervical myelopathy. Another example of the vertebra, this might be a little hard to look at, but the vertebra, this is a lumbar vertebra, and you can see the small joints in the back, the joints that we see between L4 and L5. There's a disc between that, and then in the back there are these facet joints. The facet joints are these joints back here. These are relatively normal. There's a little bone spur, but this tube, so we have a tube that goes all the way down the spine like so, but if we look from the feet up, we're going to be looking at that tube like this. Okay, so disc herniations might be coming in from this way, and facet joints, the little joints in the back, might be forming bone spurs this way, but collectively it might result in circumferential narrowing of the canal, causing pain and disability. But this CT shows a little bone spur here, but overall that canal, that tube, we know the nerves are in there, that's open. Over here you can see the changes that we talked about in that degenerative cascade, where the disc probably has some bone spurs there after radial tears and circumferential tears and collapse of the disc. And then these facet joints that now have these big bone spurs that are coming off and growing into that canal, causing it to narrow. That narrowing is spinal stenosis. Okay? It's real simple what we do. Like the anatomy, like to me, it's very simple. If it's pinched, you unpinch. It's for surgical perspective. It's pinched, it might hurt, maybe it doesn't. It's not complicated, you know, some very basic things. When I look back at how much training it took, well over a decade, and how many sleepless nights I've had in practice, again, over a decade. When it comes down to it, I feel like I could have learned this in like 15 minutes. I really do. Like when you break it down to its bare essentials, I don't know why medical school and residency and fellowship, why was it so long and hard? But when you break it down, it's actually quite simple to understand. So some various diagnoses, we talk about disc herniations, or HNP is what we talk about for herniated nucleus pulposus. That's part of the disc in the low back. Stenosis, spondylolisthesis. We could talk about some compression fractures. We see those as well. Not really the big focus here. This is, again, that same picture of the spine. You can see the nerves there, and if some of the disc leaks out, it can be touching the nerves there. That would be what a disc herniation might look like. I'm going to let Dr. Goldberg talk about some of the basic non-operative treatments that he knows a lot more about than I know about. I'm going to let him go over some of those things. But the treatment from an operative standpoint, again, is focused on a couple of things. Number one, making the holes bigger, okay? Whether that's small holes like a laminotomy, or bigger holes like a laminectomy or a partial laminectomy, something called a laminoplasty, and then MISS, which would stand for minimally invasive spine surgery, which I have an interest in. But this is what a basic laminectomy looks like. Everybody has heard of laminectomies. I don't do too many laminectomies, but I don't have a problem with people who do. A laminectomy is a great procedure, and all it means, the lamina is the small part of the bone. I'm going to go back a slide. This is taking that spine, right? It goes up and down on me like this, and now we flipped it up like this. And so we see this tube. This back part, we talked about these facet joints. This part right here is what we call the lamina, okay? It's basically the roof over the nerves or the spinal cord. And the idea of a laminectomy is just to remove the roof so that those nerves go from here to like this, almost like a U shape, right? So if I just took out this bone or a portion of this bone, you got to leave some of these joints in. You got to be mindful of how much bone you take away. But if this roof was coming down on us all, and a tall guy like me would have to crouch, if I took off, if we removed the roof, I'd be able to stand up tall. That's all a laminectomy is. Laminotomies or things like that would be if maybe I was standing on this side of the room and I was being pinched and we took off this side of the roof. I would have to do a laminotomy if I wanted to get to that disc. I would have to make a little hole here and move those nerves out of the way to shave down that. We're just taking off a little bit of the roof. That's all it is. Like I said, real easy. Not really sure why it took so long to figure this out. So the old way, and this is looking at a spine if we're just looking at it as if the patient is lying flat, lying prone, and we see all these bones which are the roof. We're looking down on the roof, and we know the nerves are underneath, and we just take off the roof. In this particular case, they're taking off the roof at several levels, like at L2-3, L3-4, L4-5 laminectomy, a 3-level laminectomy. Here's what it looks like if we're again looking at that sort of same picture. You're just taking off a portion of the facet joint. You're just taking off that roof so those nerves can stand tall, right? You may be shaving down discs or shaving down bone spurs or what have you. But the benefits of minimally invasive surgery is we're not making such a big incision. We try to limit our incision. We try to limit our dissection. We try to limit the bleeding. And by doing so, cutting down on other things like operative time, we're going to limit our infections, resulting also in shorter hospitalizations and hopefully earlier return to function. So what a minimally invasive surgery might look like, and this part isn't important, this part more important is where we sort of localize that level. This is again tough to see, but you can see the vertebra here, right? And this being the disc, we know in this particular case, let's say there's a herniated disc, and as we localize that level under an X-ray, we put dilators before we add a tube onto the lamina, and then you make a little hole. Here's that tube. Here's what it looks like in the operating, or it might look. You make a little hole like this, and then ultimately that's a big chunk of disc that's coming out there to relieve pain and disability. The other thing we can do in addition to that is sometimes patients need more than that. And through those small incisions, sometimes a couple of 1-inch incisions, you can actually take out the whole disc or fuse those bones together. There are some patients that require that. If too much bone is needed to be removed and the spine stability is compromised, then you would need a fusion. And through those small incisions, you can do that as well. Again, there's sort of the newer way where you use a smaller tube and under microscopic intensification, and then there might be a bigger surgery, which again sometimes is necessary. And the reality is, if you have the pathology, I believe that can work as well. It's just a matter of, again, getting that shorter hospitalization out of it, getting earlier return to function, using less narcotics, which is a big issue here in Pennsylvania these days, less infection and so forth. So doing more minimally invasive surgery, and I do lots of different kinds of procedures. I don't want to bore you with all of that, although that's really the stuff I like to talk about. I really do. But the pros would be less pain, less bleeding, the fewer infections, shorter hospitalizations, and improved result. The cons, sometimes if you have a really bad problem or you've had multiple surgeries or you have hardware that exists in there, sometimes it's not the best thing for you. You have a smoker. Smokers don't do so well in my experience because it's harder to get bones to heal if you want to fuse a smoker. So sometimes you have to make a bigger incision and put more biology in there to get these things to heal. And then some people are just too great of a surgical risk, although I don't see that too often. And then the other thing I always put in there is learning curve. I've been doing minimally invasive surgery in the Valley for over 10 years, and I thought it was going to be the latest, greatest, and everybody was just going to be behind me, and everybody was going to catch up. But there are lots of docs that say, well, the way I do it works well, and why would I change? Because it takes a long time to learn. There's a big learning curve. There's a long time, and there's complications, and there's issues when you do it through a small, there can be issues when you do it through a small incision, and some people just don't want to learn, and that's fine. I'm surprised that it hasn't taken a hold of this area like it has in a place like San Diego or California, where I grew up, where if you're not doing this, you're not in business. And this is how we make a living. This is how you want to be in business. Whereas here, it hasn't really become the standard of care. But I'm still doing it. They can do their thing. I'll do my thing. So one of the things I really like is the fact that the hospitalization is much shorter, which is good for me. We don't have to see you in the hospital. There's less issues that can arise while you're in the hospital. It says 3 day up there, but really it's 2 days. I think my average, even for big surgeries now, my average length of stay in the hospital is like 2.1 days. That's all comers. That's that stay overnight. That would include people who have really multi-level fusions, big problems. They still are going home after 2 days. When I started, 4 or 5 days over at Muhlenberg Hospital was the norm, and I think it still is the norm for some surgeons that go there. Really limited IV pain medication. We've gone away from that as well. But at the end of the day, I do believe that spine surgery works, and regardless if you have the right indications in the right patient, you have the right motivation, that you can have improved function with decreased neck, arm, leg, and back pain. So the indications for surgery, generally speaking, these are big generalizations, are failure of non-operative treatment for 6 to 12 weeks, any progressive neurologic dysfunction, that is to say, yesterday I could raise my arm, today I cannot. That would be not a good thing. A functional neurologic deficit, I cannot lift my foot up this way to clear my foot during the swing through of phase of gait. That would not be good. Incapacitating pain, although most of our insurance carriers do not recognize incapacitating pain as a reason for surgery. And then there are other stuff. I mean, every patient is different. Every story, while there are lots of similarities, every patient is different. And what you get when you have a surgeon that operates 400 to 450 times a year, with that experience, you know who's going to fail non-operative treatment, who is just going to ultimately end up on the table or in the hospital, and who is not. And that can only come if your surgeon has experience. So in conclusion, I think minimally invasive surgery is a great alternative to standard open procedures. Again, we talked about the benefits ad nauseum, and I think the outcomes can be very similar to the open procedures, but you get to where you need to be sooner. And this is a picture of my son. It is Father's Day weekend. And unlike my dad, who would never say this, it's a great privilege to be his father, and that's really what I'm recognizing. He's an animal. He's an animal.